Good morning, everybody. It's a great pleasure to welcome you on our TTX New Nordics 2024 event. I'm Sven Parkel. I'm the General Manager of Tartu Biotechnology Park. We're one of the main organizers and initiators of this event series. And we initiated this event series last year to provide a platform, provide a discussion ground for topics that matter on providing better healthcare and help to bring stakeholders together to discuss these relevant topics. And also as an effort to enhance the discussion in the Nordics area on digital therapeutics. And this year, before I go further, just to show you the link as well, we have created an online streaming link. So if there's someone you know that would be interested in listening in but cannot or couldn't join us today physically, then please share the link either directly in your social media or directly to the people who might be interested in joining in. Well, this is the second year of TTX New Nordics event. It's also a second year where Estonia has been considered to be a strong innovator regarding the European Innovation Scoreboard. So we have been there once before. It wasn't last year, it was a little bit before that, but we're still lagging a little bit behind from the strong leading innovators, and those are Finland, Denmark, Sweden, and Netherlands. So I hope that the event and also the Estonian Health Tech Week in general helps to create new value for stakeholders in the sense that we become more innovative and we are able to provide better healthcare in the region and to be known for our innovative patient pathways and the new technologies we use in hospitals and not only for cement and buildings. There are many components that we already have, many things that we have done right over the years, but there are also ways to go still. Our first session, so we have 3 sessions today. There are 3 main concepts that we want to discuss jointly with you. The first session focuses on the health data and health data space. And while the decision to create data spaces was established early 2020, there have been many discussions about different formats of those data spaces, either regarding the infrastructure, regarding the ethics, patient rights, research, business models, and so forth. And when we look at the countries leading that discussions, that we see that Finns are doing very well. So we have the health data discussion, which is currently led by Sitra, FinData, and other great Finnish organizations. Sorry. But there are other initiatives as well to advance the topic, and for example, Scanbalt with the in collaboration with Spanish and Portuguese health clusters and with another European network called CIBER, is developing and providing a platform for stakeholders to discuss topics that we are not talking about yet. And we're providing this collaboration platform through eHealth project. But what's happening in Estonia? So what kind of opportunities do we see going forward? And the day started with a keynote from Jaanika Merilo, who's the head of eHealth strategy and the Estonian Ministry of Social Affairs. After her keynote, we will dive into this topic further under the insightful eyes of Montse Daban from Biocat in Catalonia. And she will be joined in a panel by the minister, also by Elina Trakvik from Sitra. Sitra is the lead partner in the TEHTAS project, which is the lead project in the European Union for developing the common health data space. We have also Sander Pajusalu from Tartu University Hospital. He's the head of genetics and personalized medicine. And the panel will also be joined by Meelis Joost, from Estonian Chamber of Disabled People to bring in the aspects of patients. After the panel, we have time for lunch. Hope you will find that 1 hour sufficient to eat some food, but also have a chat about the topics that were already discussed and that you want to discuss further. And after the lunch, we will carry on with the second session, focusing on reimbursement models in health technologies. And this will be kicked off by Robin van Kessel, who is Andrew Hoffman Fellow on Health System Financing and Payment Models at eHealth and World Economic Forum. He will also be joined in the panel by Jaanika Järviste from Estonian Health Insurance Fund. Jaanika leads several novel approaches on how to bring new technologies to hospitals, to finding the reimbursement models. Vincent Vincemer from the French Ministry of Health and Prevention will bring the view from France, hopefully discussing some of the aspects of the PECAN. And Thomas Koropka from German Network of Health Regions adds the view from Germany and hopefully also discuss some of the aspects of the TIGA framework. Discussion is moderated by Jaanus Pikani, the chairman of Scanbalt, with extensive track record in healthcare in different roles. After the second session, we have a coffee break, and when we return, we have keynote from Thomas Koropka, discussing the human side of AI and TTX, and the topic will further be dissected with help of Priit Saluma, long-term entrepreneur, currently founder of CEO of Better Medicine. Also Pilvi Ilves, head of radiology at Tartu University Hospital, and Liisa-Lotte Lääne to bring the legal aspects. She is the head of life sciences and healthcare sector group at Sorainen. And to keep all that AI in check and under control, or maybe to let it loose, and we don't know yet what's going to happen, we have Paula Salm-Sandrak. She's a product strategist for eHealth and Health AI at Bayer Pharmaceuticals. And to wrap up the day and perhaps make some final conclusions, we're blessed to have Kristiina Sepp with us from Enterprise Estonia. And then after a long day, we have some time for some refreshments and to make some final conclusions among ourselves as well. So before we start, just to point off, we have Triin and Keiu here with us as well. They're back there. If you have any questions, any comments, they're waving, please let them know. So for the opening words, I would like to invite on stage from the Ministry of Social Affairs, Riina Sikkut, Estonian Minister of Health.
Thank you. Good morning, and I'm very pleased to welcome you all in the heart of really the science, the research, the health and care of Estonia. And I am not a caricature of Estonian he state minister with a paper-based notebook, but it's actually to demonstrate that the cross-border collaboration, it's Paris Santé. So I welcome the French participators as well. Recently, we got the news from the digital decade. Everyone is ranked and clustered, so Estonia was clustered as a trendsetter and as one in top 3 in eHealth. I'm very happy about it, but also I feel it's due to something we have done in the past. But trendsetters should set the future, show what's coming for every one of us. Generally, ministers receive complaints. Someone didn't get the care they expected. Something doesn't work as it's supposed to be. So laws always need to be changed. But in terms of eHealth, whether it's in Estonia or abroad, I usually get this good feedback. Last year, we launched the Terviseportal, patient portal that shows you your past health records, and you can register for appointments. You see referral letters and digital prescriptions. And I actually get good feedback that this is something we have been looking for or waiting for. And also the clinical support system for our GPs or family doctors. The first steps in the past years that have been weighted and welcomed in the health sector. So I feel this is also an opportunity to say thank you, because the credit I get or Estonia gets, it's actually the hard work many of you have done in the past, during the past 20 years or something like this. So, and this is what we can see or get the first results from. But when in the ministry or with you, I discuss what should be done. We usually find that, oh, there's legacy, something in the legislation, lack of resources, habits we cannot change. We see a lot of obstacles. And some of them will be discussed today as well, and it could be in terms of reimbursement or other aspects, but I would like to start with values because the European health data space, the negotiations and discussions during the past years can be seen as a success. It's first agreement of this kind. It's a step forward in many aspects, but actually I feel that I failed because I wanted so much more. And since European Union is a union of values, when the human rights, the freedom of goods and people to move, and so on. But in terms of healthcare, the issues we cannot agree on reflect the values we have. We discussed a lot about patient choice. And in December, I had a very interesting debate with European doctors. They had their General Assembly in Estonia, in Tallinn, and they asked about the European health data space and what does it mean, and what about doctor-patient confidentiality, and what about all the risks that come to, and why can't we respect patient choice to opt out of digital health record, to opt out of all these digital issues. And it's a valid question, and it reflects that we are quite risk-averse, we value privacy and confidentiality, but the other side of the coin, we should be very then upfront with patients. Yes, if we give you a chance to opt out from digital health records now, you have to understand that we are taking away choices from you in the future. Because in the future, healthcare will be more personal, more digitalized, more apps and tools are used to personalize prevention or smooth patient pathways. And this cannot be done for people who 20 years ago opted out. No one will manually digitalize your health record. So yes, we can give patient the choice, but this has to be a fair choice. There are upsides, there are downsides, and if the patient is willing to actually take or leave everything that's in the future in digital healthcare and digital therapeutics away from their reach, then yes, they can make the choice. But currently, on a political level, we are arguing patient freedom, patient choice, right to opt out, without actually honestly discussing the other side of this choice. And that's why I'm very happy that with the high ranking of Estonia, there were two aspects that we stood out. One was high level of digitalization, that everyone has digital ID, electronic health records. We don't give the chance to opt out because we don't see digitalization as a choice, but something that is inevitable. It's a tool that actually enables good quality healthcare provision now and in the future. And the other aspect was easy access, because the other argument, in addition to giving patient the choice, I get this, oh, the healthcare workers and the patients, they don't have digital skills. So it cannot be done. We cannot do it quickly because we first have to give people the skills. With the easy access, where Estonia ranks high, well, with most of the tools, no skills are needed from the patient side, particularly the digital prescription or e-prescription that we started with. Well, with paper-based prescription, you have to carry it along, you have to remember it, you have to, decipher what's been written by the doctor. With digital prescription, it's the same pharmacy you go to. You just don't have to carry along that paper or understand what doctor has written there. So there are no digital skills required from patient side. And the example I have brought the most internationally is that after we have almost 100% digital prescriptions, so we realized that we can use this data to achieve equity goals. With even before the digital prescription, we had this additional pharmaceutical benefit in place. Starting from January, the patient calculated that on prescription medicine, he or she has spent 20 euros, 50 euros, 100 euros. If you reach 100 euro ceiling, state covers 50% of everything extra. If you reach 300 euro ceiling, state covers 90%. So the patient has to calculate the prescription medicine cost, cover the cost, buy out the pharmaceuticals, know about the benefit, apply for the benefit, and then wait for the reimbursement. With digital data, the person shows up in the pharmacy and the IT system says that, this patient has reached the 100 euro ceiling, and no one will charge this extra one. The benefit starts immediately. It's automatic. The patient doesn't have to know about the benefit, ask for it. He just receives it. And so during this 1 year after implementation, we managed to reduce the number of people who spend more than, I think, 300 euros per year on pharmaceutical prescription pharmaceuticals from, I think it was 12,000 something, and then the end was 121 patients. 121 patients who spend more than 300 euros on prescription medicine. So if we want to target any additional benefits, we know who actually need it. So digitalization is not just for efficiency targets, but we can, as a state, achieve equity goals with it as well. And digitalization, data, the value of data, this is what most of you use in your work, most of politicians even use in their work. It gives so much possibilities, but we usually discuss risks, and we need to do it. New solutions, new risks that have to be mitigated. But for me, this curious thing that also reflects the cultural differences in Europe, but between people as well. You know, I have high cholesterol. And since I have donated my blood sample to the Estonian Genome Foundation, I just found out that I'm sensitive to warfarin. And my genetic risks for diabetes, they're high, although there are no diabetics in my family, but genetic risks are high. I have all this information, and I'm happy to share it with you, but I don't post the pictures of my children into social media. But for some reason, in terms of drafting legislation, we see that health information is somehow more sensitive, more valuable, something that should be kept secret. And for me, it also always poses, how can this be? We are so willing to share every other aspect of our lives to complete strangers. But with health data, and if there are Germans, you can say that whether you agree with me or not, particularly with German doctors, I get they said, it's in the room. There are just me and my patient. Why should anyone else know what we have been discussing? Why should anyone else know the information? And I don't see that health data, considering the potential using the data, even for research it can offer, that the question has only one answer, that yes, it's a patient-doctor confidentiality issue. Looking at the public good we can get, there are so many arguments that say that, yes, there are definitely things that you can discuss with your doctor confidentially. But based on your very trusting relationship, this same person can get better services, better targeted pharmaceuticals, and the society can whatever, smooth patient pathways or make better political decisions on how to reimburse or what to cover from the health insurance fund budget. So this is, whenever we discuss digital health and digital therapeutics, I think in Europe we should start with what do we value? How do we estimate the risks? What can we agree on? And have a really open debate on about the changes in healthcare service provision that are needed in the digital decade and the digital century. But looking into the future, so good quality data, standardized data, and we challenge with that because a doctor can read your patient records and have all the detail. But for a researcher, you need rather a large quantity and a different quality of data. And access to the synthetic data, anonymized data, using the effort we put and the investment we make into the digital infrastructure. This is not just for providing individual services, but we have to make use of the data in research, in developing pharmaceutical services, digital tools, and if we in Europe implement the European health data space and actually are able, in addition to patient summaries and digital prescription, make data available. We have this good cooperation with Finland, and I think we see that the potential and the future very similarly, and I hope the cooperation carries fruit soon, even with implementing European health data space. I say there might be individual models, but there are more potential if we implement it in a similar way and move in the same space. Digital prescriptions, I have mentioned already. We started cross-border accepting of digital prescription 5 years ago with Finland. We were the first ones. Now we have 40,000 digital prescriptions that have been brought out from not in the country that it was actually prescribed. Latvia joined in March. We have reached 1,000 prescriptions that have been reimbursed while traveling or working abroad. And Lithuania, this is not public yet, but Lithuania will join soon as well. So there are very practical things that work for the patient, but we can achieve much more in cooperation. And I hope that in the panel we can discuss it. And I will, 22 seconds, the only thing to end with, it is collaboration. Collaboration of public sector and private sector, doctors and patients, Estonia, Finland, Latvia, and all the other European countries. Cooperation, because the challenges are very similar and the solutions need to be smart. We don't have the smartest heads in Estonia, although the PISA tests are very promising, but in cooperation we can provide the very good quality healthcare services for each and every one of us and European citizens in general. Thank you.
Thank you. I'm very thankful for the Minister for setting the stage from the perspective of a patient, because that's what we're here all for, to bring more value to the people who are in need. Next up we have Jaanika, so please come on stage. I will have a clicker for you ready. 2. Here it is. I hope that works.
Thank you, appreciate it. Thank you, Minister, and happy to continue with patience and collaboration, actually, because this is what European Health Data Space is all about. And actually, thank you for inviting me to my hometown, Tartu. I have always a good excuse to come here for this kind of conference. But Estonian Health Data Space, I will be happy to share what plans do you have, at what stage is the European Health Data Space right now, and also to engage you and to discuss the ways how you can be engaged in implementing this EHDS. So EHDS was agreed upon by Council and Parliament on March this year, but it still is awaiting for the second vote in the autumn this year. And then it will actually come to force, probably October, November, and then we have still 2 years for implementing acts. Why it's important? It is important to understand that even though we have a directive in place and we understand the main principles, we don't have all the details yet. We don't have all the answers yet. We don't have the technical descriptions, all the complicated ways to implement it. Not everything is left to national standard. It's, again, cooperation also cross-border. So this is why we don't have all the answers yet. We will be working on them in 5 work groups together with European countries during 2 years. So I think by 2026, by the end of it, we will probably have all the answers and kind of green lane to execute everything. We're very eager to start sooner. You know, Estonians are agile and quick, and why cannot we make it faster? Sometimes we can, but I will be happy to share also timeline and see where we can go faster, where we have to wait just to make sense and not to do 2 times same thing. But truly, EHDS is about the patients and about European health data space, about the data, and everything related to patients' care, because this health data enables to give better care as the doctors are more informed, as the patient can give their input and be proactive in the care, and as well as the secondary data, which gives so much opportunities to research, development, and take use of this new technology. So all it is about is developers, patients, and data. So now, when I talk about the patients, actually, who feels they are gurus in EHDS? Can you raise the hand? Thank God. Okay. So I will tell the general principles as well then. So EHDS basically is all about the patient and giving patient the control over the data. So the patients will have the right to opt out for certain diseases in primary care and certain ways to opt out in secondary care or secondary data. And it was widely discussed, as Minister mentioned, when you should have the opt-right and whether it's for public good to have as much data as possible. So we were preaching for pseudonymized, anonymized data should be available for research for any researcher, because opting out would create bad quality data sets or not reliable data sets. We made a compromise, so there are certain opt-outs in primary care or primary data. Of course, maybe you don't want everyone to see your diseases or to see your diagnostics, but in secondary data, it's for greater benefit, for better policy making, for better research, to offer you a better care with less risks. Then it's about patient data, that the patient data should be available in a country, meaning between the healthcare professionals in the same country, as well as cross-border, because more and more treatment is also cross-border, and people travel more, and when you travel, you want to have an access to the same quality of service, but quality means also having access to data. Because how can the doctor somewhere abroad offer you the best service if they don't know your health conditions, critical risk factors, allergies, everything that is relevant to diagnose you properly. So the data has to go along with the patient abroad or wherever they are. And I'm very proud that actually we have connected to 12 countries already in cross-border data exchange, and that means e-prescription, a patient summary. Yes, trendsetters this way, that it's not like a massive that all the doctors now in Portugal see Estonians' data, but it is about trend setting. Once one country can see, another can see, and it's a matter of time when the other countries will follow and start connecting. We yesterday met with Norway that was like, oh, we see that you're doing so good in data exchange and prescription exchange, and our citizens are starting to ask, why don't you connect? So we create also demand, which is important. And then, of course, all the data that is available in country should be available for cross-border and as well be available to research and development and to test the new applications, to test new AI models, to have the clinical research and so on. So once we have the high-quality data, and this is what EHDS is all about, having high-quality data, meaning interoperability between systems, having all the data centralized so it can be shared, then we can use this data for whatever cause, for decision-making, for research, and so on. So what we're doing in Estonia right now is we're working on improving the data quality. Sure, we have loads of data starting since 2007. Since 2007, everything is digital, basically. So we have a big load of data. But yes, the quality is an issue, meaning that it's not all standardized, as Minister says. It's not all having the highest quality expectations. But then we can also use AI to improve the quality, as well as to improve the documentation standards, so that we would be gathering good data that would be available, again, for doctors and for researchers. And yes, a very nice example is a cooperation with Finland, because we have only like a data maybe of 1 million people, maybe 1.3 million people. Finland has a health data of many million people. If we pull it together and given access to researchers, it is so much more high-quality data, and so better results can be achieved in working with the bigger data sets. So also data should travel abroad, not only the patients, because then we can really provide the results and care for these patients in European Union and outside. So this is kind of a small concept of the EHDS, basically, in very simple words. The central system, or our TEHIC, should be able to get the high-quality data, which is interoperable with other systems by standards set in EHDS, and the data should be then shared to other cross-border exchange countries as well as secondary use. It sounds so simple, but it's not actually, as you can understand. And many countries that have fragmented systems, like yes, Germany, Austria, they cannot even connect the databases to have it centralized, to share it cross-border. Yes, very happy that we have a great legacy, that we made the right choices in regards to architecture, that we're so like flexible, and we made so wise decision before certain legislation like GDPRs and so on. We managed to make like vital changes and decisions. But for example, today, if a researcher wants to apply for data, yes, it is a like very busy picture. This is the point. If a researcher wants to apply for data for secondary use, for research, for modeling AI, for whatever use, they had to go through many different complicated procedures, unfortunately. For example, when a scientist needs the data from different databases, like healthcare, maybe education, maybe population registry, they have to apply from one place the data, then have the data permit, then from other place they have a data permit, then from the third place, and then after a long procedure they will understand what kind of data is available, what is the quality, whether they can have it or not. And it's very twisted, meaning it takes time. And yes, it's doable, of course. We constantly have like data applications, but it's a little bit hectic. And we have a dream that in a few years, I will come to timelines, we will have much improved statistics, which means that certain data shouldn't be probably received as data as such, but the statistics might be enough if it's well modeled and well analyzed. But as well, we're dreaming about having this, let's say, one-stop shop for data, which means that the researcher could apply for through one application management system the data from different domains and different ministries. For example, the same researcher that needs this data from, let's say, Ministry of Internal Affairs, maybe education, healthcare, they don't have to like apply for the data from 3 different places, 4 different places. They can apply from one single one-stop shop or centralized system, and then it will be processed in the background. So the request will be made to different ministries, to different data protection authorities, and it will be like a very good and smooth CRM, saving so much time when you can have like one application, many ministries cooperating. This is our dream on what we're working on with Statistics Estonia, because they have today quite good centralized system, as well as Ministry of Economics, as well as Enterprise Estonia. So we are dreaming about not only having this easy application management process for Ministry of Healthcare, but we see it as holistic picture. Very often more data is needed, and it should be a smooth pathway also to receive as much data as needed, as easily as needed. Yet we have, of course, ethics committees and certain kind of, let's say, patient protection mechanisms in place. Coming again to EHDS, we have certain building blocks of EHDS, and one of them is the certification or self-assessment of software developers. Very probably many of you today are developing some kind of application or software related to healthcare or wellness. And in this case, if you have a healthcare application, it should go through self-validation process. There was a huge discussion in European Union whether we should have certification, third-party certification for software solutions that are interoperable with a central system, or it is enough for the software developer to say, yes, I comply with all the rules. He confirms, for example, that yes, the data is of high quality, it's all good. And also the same validation works in other European countries. We actually are very happy that we didn't have this third-party huge auditing process, which would be very costly, but we have a light version of, yes, I confirm, yes, he confirms, all good, you're minimum lightly certified, let's say. But here we should wait also for the guidelines for the validation. So we would be ready to do it. Today we already have in place certain interoperability standards with TEHIK and between the healthcare service providers. But again, it needs one European standard, because only then the software that is certified in Estonia is also accepted or certified in other EU countries. So sometimes it's about cooperation that gives value, not running as fast as we can. Then, of course, we're working on simplifying the data request process for secondary data. So we're trying to understand where are the problems in the process, basically. That whether, for example, someone who applies for data doesn't understand how to apply for data, where to apply for data, how to fill in all these complicated formulas. And again, Enterprise Estonia, thank you for working with us to understand where are the bottlenecks. Then we are creating and analyzing what is the most efficient solution for this one data application management, where to submit your application, where to receive your permit, whether it's one centralized solution with Statistics Estonia, whether it's the Ministry of Healthcare. And we also have European grant for that, actually, and we're working in sync with European Union. And it all should be, again, ready by 2026, because it should be cross-border and pan-European, basically, also receiving the European requests, and it is, again, about cooperation. Then we're working on creating the catalog of datasets, meaning that, for example, when you need data for research, you would already know that, okay, here is a catalog of what is available and how fast it's available. Because you need to know basically what kind of data you have, what needs to be prepared, how much time it will take, so you can plan basically your research also. And this is where it's interesting to cooperate again with Finland and other countries, because, for example, when you can see that in Estonia, there are not so many data sets that the researcher needs, but maybe Capsule and Fen data has this data. So why not place this data into same secure processing environment when the researcher can use several countries' data, because it really magnifies the results of the research. And this is what the EHDS is all about, really, like utilizing your strengths. So secure processing environments. Today, we're giving out data as data. And actually, EHDS says that data should be in protected environment, that it could be modeled, it could be developed, researched, however is needed, but yet in protected environment, because this is again a data protection, that you cannot download the information, you cannot resend the information, you have an access to environment that has all the tools you need. And here we are thinking about being as flexible as possible, meaning not creating this one government environment. No need to do that if there are alternatives. And basically, as soon as we understand the technical description of this environment, what is needed, as well as we have minimal legislation, what we need. Finland has Secondary Data Act for that. We can start using any secure environment. Maybe Tartu University, maybe Finland capsule if someone has like cross-border requests and so on. So as long as it corresponds to the needs, it is good to go. And yes, as I mentioned many times, cross-border cooperation, because again, the European health data space is about European data, meaning that the data travels with patient, as well as the data should be available cross-border. And EHDS actually has a pretty, let's say, long timeline, meaning to implement it all that we have dreamed about. Europe is planning to make it by 2038 maybe. We're planning to do it as fast as possible, as soon as we have the implementing ducts that we need. And actually, we are already corresponding to very much of it, meaning in regards to patient rights, we have the opt-out rights, we have the log files, we have the right to nominate representative. So in regards to making primary use data sets available, like the patient data, general data, prescription data, medical images, we have it almost all in place already. So we're not waiting or lagging behind. So if the timeline is saying 2036, then yes, many countries might make it by then. We might be ready much, much sooner, and we're intending to. So, and of course, collaboration and how can you collaborate? We're right now drafting an eHealth strategy, which tries to define what government does, what government prioritizes, and what government doesn't do, and what could be done by private sector. Because again, when we have a certain mission, and mission is to offer personalized care, prevention, offer better health care, that means that it's not just government, it's a private sector, it's investors behind them, it's finding this smooth path to co-create the solutions that support our healthcare, whether it's like simplifying the certification process, whether it's creating sandboxes to test the innovation, whether it's engaging healthcare professionals to develop the new solutions. And for that, we will have eHealth strategy that will define our cornerstones. And again, I'm looking at Christina, Enterprise Estonia also, and we will have work groups. First work group will be research and development, where all the IT companies, the developers can join in and tell us about the bottlenecks. For example, what is needed to take the solution to market faster, to export them more smoothly. So what is needed? And another work group is, of course, about data, because this is all what it's about. It's European health data space or data space to support the patients. So we're very happy to cooperate already with 20 stakeholders, the associations, the unions, the patients, the doctors' unions, the IT companies, and we will continue in the format of very hands-on work groups on how to make it all happen together. So also as Minister ending on collaboration and cooperation, and we'll be very happy for any question. Thanks.
Thank you, Jaanika, for a great overview. Yes, we have a question. We should have a microphone somewhere as well, so that people in the audience can hear. Trine, can you tell me, do we have a microphone as well? Yes, it's there.
There you go. Hello. Thank you very much for a very good presentation.
Thank you.
And a very interesting topic. And I totally agree that this works needs to be done. And maybe this question might, you maybe have already said this, but I wonder who will own the data that will be
Patient,
collected?
always. And this is a cornerstone of EHDS also, that the patient owns that data. Basically meaning that the patient is in control of the data. When the data is opt-in, when it's opt-out, who has access to it, so it's about the patient owning the data. Yes, in certain cases, let's say, we create a digital record as soon as the patient is born. It cannot not exist in digital sphere. In this way, the data is available to doctors, but the patient can decide how much data is available to what doctor and to what use. So it is still about the patient who controls and who also, for example, can decide who can see the data. Is it the representative? What doctors can see the data? It's, they can opt out, but they can see also log files, who has access to the data, why they have access to the data. So the patient should be in control of the data.
Well, that's interesting. Thank you.
I hope it will work this way. We're still working on it at least.
Hi, thank you for presentation. My name is Kaspars. I'm from Latvia, from Riga. So
Welcome.
thank you. I almost feel like home. One thing, what I heard that you're still developing some paperwork on or legislation on secondary data use. You can reach out to FinData and to Riga as well, to Latvia, because we just introduced secondary data law.
Yes.
It's on public right now to see how it goes. But basically, we are like awaiting a little bit on Europe in that space as well, maybe to have some adjustments there.
Yes.
But the work has been done, so you don't have to, do it one more time. Maybe you can have some ideas there. But then the second question about collaboration, exactly, you mentioned work groups. So normally those work groups are happening either in the ministry or something, and they are with the local stakeholders.
Yes.
Will you consider to open up them for international cooperation as well? So, for example, in the data, we would like to participate, and how it can be done for all of us.
Absolutely. In regards to best practices, we're working together with FinData very, very much and very tightly and almost on a weekly basis. And Latvia also collaborating with the government in regards to secondary data and also in the future pooling together the data. So we're very in sync. Thank you. But I think it's a very cool idea, me personally, to engage also international stakeholders, and whether it's through IT clusters or through some associations, we should think about the format, because, for example, in our case, we engage the associations because we have like so many stakeholders. But in some format, I think it would be very nice and interesting to engage also like international units, association, corporations that would be interested. Definitely it adds value, absolutely. Thank you for bringing it up, actually. It's a very great idea.
We have a question there.
Thank you for your overview. I also have a question about secondary data use. What's your understanding or view? Will this health database system be mandatory for researchers who want to use health data for scientific research and development? Or do you see that the scientists and researchers, developers, they have alternative paths to use in the future when the EHDS will be in force?
Yes, well, EHDS doesn't force you to use in any way. It gives you a faster lane to receive the data, which means the single data application management point and so on, but it does require you to use the secure processing environment. Meaning that the data is secured in a safe way, in secure. But having said that, you can choose your own environment. That we don't restrict. For example, if the University of Tartu has an environment that corresponds to needs, very welcome. We're very happy to share it wherever you need. Maybe Tallinn Technical University has their environment, for example. Finland has 9 different environments. So we don't restrict as such. We don't send out data as files anymore, but this is again for data protection. So rather the EHDS creates the fast lane to receiving the data in a secure way and also processing secure way. So I don't think it contradicts anyhow with researchers' needs, especially that maybe you have much more tools available. When you have in one processing environment maybe tools that support AI modeling, in other you have different tools available. So I would say it's rather like creating different opportunities, not limiting yourself.
But do I understand correctly, if the researcher doesn't want to use this system, it still has to follow the same security environment requirements that will be in place for researchers that do choose to use the system? Is this the understanding of Estonia?
Choosing the system, it's about the data protection, meaning that you will have access to the data that government provides from any information systems, especially when it's a huge mass of data, through the secure environment. Meaning that, no, you cannot receive them as Excel files anymore, because it's not data protection, and it's not controlled way. So yes, we will have access in a controlled, secure environment again, and it's not like an option, I want to receive Excels. It's also the basic data protection that probably should be in place.
Okay, we should discuss this further someday.
I'm Peter Padrik, oncologist. Thank you very much for this nice presentation about the future. But we have the problem that patients are getting serious diagnoses already now, and they are dying already now from diseases. And we have already existing data sets. For example, in Estonia, we have Estonian Biobank, which is quite a unique data set, and actually this is meant also to be used in healthcare as healthcare data sets. But unfortunately, currently, this data set is relatively closed for healthcare service providers as well for health tech enterprises. Could you please describe also current ministry's activities to open already available healthcare data sets, at least not maybe in European level, but more in Estonian level?
Yes, thank you. The genomic data should be available for the research as well, and we're working on amending the legislation right now in regards to making it available. But the data sets that are already, that we have, they're constantly available, and they can be applied through the common process with TEHIK and with Ministry of Social Affairs, going through all the ethics committees and data protection inspections. And we have, like on a almost weekly basis, new applications coming in. It's not that we don't have a procedure and we don't give out the data. We do give and constantly do. It is about simplifying the process, meaning to make it even more smoother. But in case you have any data need today, we are very happy to respond to it, and we even have resources actually to make these data sets available, also additional data sets. For example, when you see some needs that haven't been met, for example, you need data from hospitals, from some EHR systems, then we can also make it available upon request as soon as we understand what data is needed. Because, for example, we have a huge pool of data sets, as you know better than me, that are not structured and are not so well, maybe, there is so much free format and free text and so on, but we can make them available with good quality as soon as we know who needs what data sets. So basically when the request comes in, we're saying that we already have this pool of data sets available today, but if you say you need some additional data, we can always prepare as long and as soon as we know what you need. And your needs will be known based on this application, that I need this data in this amount, and then we will even say that, okay, great, unfortunately we don't have it, but Finland has it, and they would be happy to provide it as well. So it's available already, we're just simplifying the process. Thank you.
Thank you, Jaanika. We don't have time for more questions now, but I'm hoping you will stay for lunch so people can still have a chat with you a little bit later.
Yes, thank you very much.
So we will move on now to our first panel. So this will be led by Montse Daban from Biocat in Catalonia. I will ask her to go on the stage, and I will ask Minister to also join her. Also Elina, Sander, and Meelis. Please grab a seat.
Well, thank you very much. Thank you, Sven, for this kind presentation and the mention before. Thank you, everybody, for being here today. I'm very honored to have such a panel with authorities, with experts, with people that I consider friends already and that will be friends soon. So that's very, very nice moment. Also because it's the end of our project EDA. I thank you also very much, Skambald, Tartu Biotechnology Park as well, and everybody that has been supporting this event. This is about unlocking the power of health data for digital therapeutics, because this is the subject of the conference today. But actually, it is also an opportunity for us to explain what we've been doing for 2 years before with our project with EDA, unlocking also the power of health data for the different countries that we've been visiting and also making some studies about. So I would like to first refer to that a little bit, but let me just go back to some of the comments that we've heard in the previous speeches and by the minister and by the responsible of health data also, by Jaanika and by Riina. So the thing here is that there's a path that is inevitable. And what we have been doing and we will be doing is making this simpler, as it was said before, less complicated, and accompanying the different stakeholders for that to happen. And with collaboration, it has been mentioned many, many times today, that is very, very important. So the first thing is for digital therapeutics. Why? Because this is better interventions, therapeutic interventions based on evidences. So the first problem we might face is how we harmonize those evidences. That's important. The second thing is all about technology. It's also how we share those data to make those evidences accessible or at the reach of the professionals really for those interventions. And how should patients support that? Or how can it be brought easier to the patient? So all those things have to be discussed today a little bit with our panelists, but also, like Sven said many times, at the lunchtime or at any break, we are really, really happy to comment on all that. So let me just very quickly go, if I may, to, thank you, Sven. Thanks for that. To talk about EDA. And for that, in the last 2 slides, I will also invite Annabella Veiga. She's a collaborator, a friend in this project. So EDA is about these interconnecting innovation ecosystems for common European health data space. And that is what we did for 2 years, different ecosystems in Europe, with Health Cluster Portugal, with Skambald, with the Council of European Bioregions. We have a representative of the Council of European Bioregions here today, also Alberto Baldi. So, and Biocat leading this project funded by the European Union for 2 years. So what we've done here mainly is we've been working with these 4 partners that covers almost across all Europe, and this is because we have as partners Skambald, which quite a broad area covered, and also the Council of European Bioregions with 55 bioregions. I am very happy to be the chair of the network at this moment, but it's a really active network that's been there for, I would say, like 17 years already. And what triggered our project actually was that there was 2 years ago that was mentioned, and now it's we see it there, even if it's in 2028, but we see it there, the opportunity to exploit this growing volume of health data for the benefit of patients, for the benefit of society, for healthcare and for research and innovation, but for policy making, to do things better, to approach the regulatory pathways better, and to go for this 5P or this personalized medicine, more preventive, more predictable, everything that we can do for the patients on this period. And Europe can really be at the forefront of that, because we can inspire international guidance. It is happening across the globe, but what we can do from here, from Europe, is the values you mentioned. Jaanika mentioned values. The values that we have in Europe, the guidance that we can provide, promoting the dialogue at all levels with all stakeholders. This is something that is very in our DNA also, the dialogue across the different types of stakeholders. And this is what we've done with EDA for 2 years, with a variety of agents, and that triggered our project. So some of the outcomes we have, and they are available at the website for you to also check and see what we have achieved, is this monitoring and this promoting this advancement. We have been disseminating the European health data space across different levels of stakeholders. We have worked with 7 case studies on EHDS about this readiness. We have worked with Bulgaria landscape, Belgium landscape, always with EU presidencies. And that is very important because we've understood that there's a moment in the EU presidencies where everybody is really willing to focus on some policies that have to do a difference, make a difference in Europe. Those are the 7 case studies. I will mention very quickly what we found from that. We have also achieved a stronger connection across stakeholders in all Europe. We have focused on this dialogue, but also we've been gathering the advancements, everything that has been achieved in these 2 years across Europe regarding European health data space is in our website as well, in some beautiful reports that have been brought by CIBOR, but Alberto Baldi is here and he can explain more about that. Like I said, we've scaled up this dialogue via the EU presidencies because this is the way to reach everybody and make this dialogue very prominent. This is the way to make everybody be aware of that. And we've also brought together a joint action plan for the next years. And Annabella, you want join me later, or you can just take the lead and explain these last slides that we will show you. From the 7 case studies, very summarized SWOT because we don't have time for that, but they are all in our website. There's strengths, weaknesses, opportunities, and threats in Europe for the European health data space. As a summary, everybody shows a strong political will. We've seen that today also from Estonia. I mean, Estonia is really a model, so it's a no-brainer. I mean, we knew that. But there's political will identified across different countries, but there will be some weaknesses and threats as well. Some of the countries or some of the landscapes are highly digitalized. So some more than, I mean, I come from Catalonia, and in Catalonia, the healthcare system is one also of the most digitalized in Europe. So we have also good examples for them, and we are collaborating for that reason. There's existing infrastructures, sorry for the format, the S went down, but anyway, across Europe, there are existing infrastructures already collaborating. So there's always a thing about data lakes or federated infrastructures. And the discussion is still there, but the infrastructures are there and they are collaborating already. And the technology is never stopping, so this is this inevitable pathway that we're following. But we have fragmented healthcare systems. Each of the healthcare systems are fragmented. We have silos in our healthcare systems. Several different hospitals working with different models of EHR, several patients are having different landscapes or their data distributed, so fragmented. Regulatory landscape in Europe is pretty much a nightmare for some of the researchers and innovators. So this, it has to relate to secondary use of health data and also all the harmonization of different regulations. That is something that has to be worked out. So need for funding for sure. And this fragmented landscape, not within healthcare systems, but across Europe. And if we want to sync all these different member states' arrival to that pathway we've seen, that is something to also to face. Opportunities in the EU presidencies, we've been following that for 2 years in the project. So every time we have been able to discuss with some policymakers at that level, they were very open to what happens. But again, some threats there or some weaknesses. I mean, we are now in the Hungarian presidency and you see the program and there's pretty much no events related to health data. So not all the EU presidencies have been as prolific on that subject as the others. So this is something that we also have to work with the policymakers in our regions, in our member states. There are large EU initiatives supporting this. Ours is small, but we have TEDAS here, and Alina will tell more about that. But very huge things happening in Europe for that, and we have to be collaborating with them and supporting them and showcasing them as well. We've been doing that in EDA for 2 years. And in Europe, we have strong research and health IT sectors. So research is strong, innovation is strong with, gaps that we are also approaching, but there are opportunities for sure there. And the threats, regulatory hurdles, we've been facing them, and the data privacy concerns, opt-in, opt-out, or right to object, which is something that we can also talk about, because this is another way of seeing things. A resistance to change, it has been mentioned as well, and the interoperability subjects. We've been discussing this with Janus a lot, the interoperability subjects that have to be addressed. This is what you find in the case studies. We are not the ones to provide the solutions, but yes, we are the ones that have been showcasing these needs for that to be reflected in a joint action plan. Annabella, do you want to explain a little bit about that?
Yeah, sure.
Thank you.
I think it's working. Hi, everyone. I'm Annabella, representing Health Cluster in Portugal. And I'm happy to give a few words, just a brief statement on the Gen Action Plan. As Monte referred, it's a deliverable of the project. So this Joint Action Plan is a comprehensive document that aims to help, support, and optimize the adoption of the European health data space in the upcoming years. So basically what we did is just gather all the information from the case studies that Mansi was just referring, also the policy input reports and interviews that we had with relevant stakeholders and also state-of-the-art information to identify the critical and main domains that need to be addressed in applying the European health data space. So we have 5 domains in this document, which are basically the governance and strategy, the regulatory and legal framework as well. We have interoperability and technical aspects, literacy and awareness, and cross-border infrastructures, of course, and it was also referred in a previous presentation. So these domains were used to structure a set of actions and guidelines that can be used and applied by health clusters and also innovation networks to support implementation of these aspects. In this document as well, we include the EU funding that is linked to each domain to help boost and improve the participation of all stakeholders. I think we can move to the next slide. This document is really towards health clusters and innovation networks. So the key role of these entities in implementing the European health data space is emphasized throughout the document. So it's really important to be aware that these entities can improve collaboration between all stakeholders. So we are referring to industry, academia, government, and also civil society. And we also have to promote collaboration between these entities in the national and international perspective, because we have shared ambitions, of course, and we can increase knowledge and awareness in these teams, and also monitor and improve the implementation of these actions. So the Joint Action Plan is going to be available in our app's website soon, and you are all invited to take a look at the document and share insights and reach out to us. So thank you very much.
Thank you, Annabella, and thank you because really you've been working in Health Cluster Portugal, this document. All this work has been in your hands, and it's been an amazing work. This has been an amazing journey of 2 years with these partners. It's ending, but what we've done mainly is accompany what happened in the European health data space landscape to support, to make it more visible, to open minds, to work with different kinds of stakeholders, this dialogue that I mentioned. Because now when we go to the panel, the matter of the panel, some of the questions that were raised is this about these harmonization of evidences, probably, or about supporting or enhancing this data sharing, and it has to do with all those different types of stakeholders, opening this very, serious dialogue without probably, barriers to the different opinions and different sides to that, because has to happen for everybody. And then the financial burdens, like I mentioned. And for that, we have this excellent panel today. I want to thank Minister Riina Sikkut. Sorry if I don't pronounce properly the names.
Very good.
Ministry of Health at the Minister of Health at the Ministry of Social Affairs. Elina Dragvik, she's senior lead at the Finnish Innovation Fund, Sitra, in Finland. We know about the FinData and all the innovations also. So Estonia, Finland, 2 models for us, for different European health systems also. Sander Pajusalu, sorry for that. How should you say Pajusalu? Pajusalu, Head of Genetics and Personalized Medicine at Tartu University Hospital. And Milis Just, he's chairman of the board at the Estonian Chamber of Disabled People. And I think that is that will help us develop this line of thinking. So we will use the first part of this panel. Every one of the speakers will address for 3 to 5 minutes, some ideas that would add to that. The minister already has been sharing some ideas, but I'm sure there's many more to share. So please, Minister, if you want to start having your comments on the subject.
We had a very interesting question about who owns the data. And I'm happy that with the agreement on European health data space, it's actually written out, yes, the patient owns his or her data, and this as a principle is important. But so patient can turn off the information about certain diagnosis or refuse treatment. This is all okay. But now the other question is there a limit to the patient ownership? And for me, the secondary use of data, where whoever, whether it's in a university or someone who works on an app to help you manage your chronic conditions, no one will come back to you to diagnose you, prescribe you, or somehow impact your behavior. But the data is used to provide better treatment and services for people who are willing to do that. And for me, the patient shouldn't have a right to opt out for a secondary use of data. Yes, I can work on primary use, and maybe I just don't like a doctor, and I take time to accept my diagnosis. But since the agreement on European level was that we allow opt-out from secondary use as well, then it's very important, that was also written down, that we have to know who opts out. Because in Estonia, you can turn off whether it's a mental health diagnosis, HIV positivity, and it's important because objectively, whether I have diabetes or HIV, it's a chronic condition. We have clinical guidelines, we have pharmaceuticals to keep your health under control. Objectively, there's no difference. But behavioral difference comes from societal response to one or other diagnosis. So we have to take this into account. And also we need to see who opts out for the secondary use of data. Because if we have all over Europe people with mental health conditions opting out from secondary use, so what are the conclusions we can draw from the data we have if we want to investigate whether it's pharmaceutical for depression or something else? Because if we don't have representative data, we need to know that who are we leaving out under our microscope or something like this. And when Estonia gathered genetic information, and now we cover 1/5 of the population, but we saw that Estonian-speaking women were very enthusiastic about giving their blood, but Russian-speaking men wasn't that interested in becoming the donor. So you have to target and get their blood samples in as well. If you want a representative sample, you have to work on that, and you have to know who is enthusiastic and sharing their data with researchers and who are not, but how large are the country differences. So giving the opt-out possibility puts us more responsibility of understanding the behavior of the certain societal groups and countries.
So I think that is, I think it's a serious statement you made here, and I think it's, and I, as a moderator, if I'm allowed, I say that I agree. Because I don't know if I have opinion here, but I do have it, because we have to be very careful on which are the provisions in which we shouldn't opt out. And I think that the devil might be hid there. So this is the detail. And I totally agree that the opt-out is a tool that can be misused for several random reasons that at the end of the day will affect the health of the population from not even from other countries, from your neighbor also, which is something that the proximity, someone has to, I think that's why the explaining about the European health data space to everybody, including all stakeholders in the dialogue, is so important, because otherwise these considerations might not reach those that have to take also a decision on that regard. So thank you very much for that statement, because I think this is very powerful in an audience and to be shared. Thank you for that. And now we move to Elina, and I will ask her if she agrees, first of all, because this is a very interesting way to start this panel, but also which have been your findings from TEDAS, or which is your findings that you want to share with us.
Well, thank you very much. And I have to say that I also fully agree with the minister.
But you're allowed.
Yes, I'm allowed. I'm the panelist, not the moderator, but yes, we allowed it for you, of course. But indeed, we in Sitra, we have been coordinating the TEHDAS project and now TEHDAS 2 joint action. And we deal, of course, very much with the secondary use of health data. And we see that the data doesn't have any value unless it is used. So I think there could be a lot of biases and this kind of distortions more easily if many people start opting out. So I think, but the text is now there, the legal text. We follow the text. It won't be changed anymore. So of course we now have to deal with the consequences, and one of those is of course then, as you said, helping to understand sort of the consequences also for choosing to, if you choose that, if you take that option, understanding also the consequences not only immediately but longer in the future. But yes, the text is there, so now we just have to raise awareness, increase people's understanding on these issues. I think that is one of the key issues. But I want to say a few words about TEHDAS towards European Health Data Space Joint Action that ran in 2021 to 2023. So it focused really on providing the options and giving recommendations, developing concepts that have been used sort of as a basis for the EHDS. The results have been kind of directly feeding into the EHDS legislative proposal. And then, of course, there was the political process. Now we have the final text. TEHDAS joint action is now over, but we have a continuation project innovatively named as TEHDAS 2. So we have now 29 European countries involved, and TEHDAS 2 will be then focusing really on these implementation aspects. So it will be feeding into the implementation acts that the Commission will be proposing soon, and also it will be providing very specific guidelines and technical specifications on these different aspects of the EHDS. So how the legislation will be implemented in practice, and what kind of harmonized way there is for the European member states, but also the different actors that are involved. So what is that they need to do so that they can benefit from the EHDS, and also improved access, smoother access to data that will be processed in a secure way. But I want to also tell a little bit about the experiences from Finland, because Finland was mentioned here so many times, and many seem to be very familiar also with FinData. So FinData really offers this kind of a one-stop shop to get access to the data, but also to process the data in a secure processing environment. And as we heard already, there are already in Finland 9 secure processing environments. So depending on your research question, you can also then choose which kind of secure processing environment and tools that are available there is most fit for your research plan and the question that you are trying to find the answer to. So I think one of the key aspects has been that in Finland we have had this legislation in place from 2019 already, and then FinData started in 2020. I have actually some news for you. We are already starting to update this national legislation. We knew that we have to do it anyway because of the EHDS, because it was not fully in line with the EHDS and the requirements foreseen there. But we already started, not we at Sitra, but Finland, the Finnish Ministry of Health and Social Welfare started this process already together with the stakeholders before summer. And there was just a second stakeholder meeting to discuss what kind of improvements should take place, what are sort of the requirements also from the EHDS perspective, and also the international aspects of research and science, because it's inherently international. So what kind of aspects is needed to be considered also from that perspective. But also we have had some challenges with FinData and this one-stop shop, the centralized approach, because it can create also some bottlenecks for accessing the data. There can be queues. We've gone a long way now to improve the waiting times. In the beginning, it was criticized a bit because in the beginning the waiting times were quite long. But now the waiting times for accessing the data is around 4 to 5 months for more complicated cases, and even 1 to 2 months for more simple cases. But still, time is money, as you know, so there are requests from the stakeholders to make this process even more smoother and faster to get the access to this data. So there are ongoing discussions together with the stakeholders. That is also one of the key learnings from the legislation that we had before, and now it has been implemented, this kind of constant dialogue with the stakeholders, understanding the challenges together and trying to find solutions together. So I think that is also a major learning that has been taken forward in Finland now. But the timeline, we'll see when exactly this new legislation will be ready, but it will take a couple of years maybe in total. We'll see. We'll hear. I will be happy to update you more along the process, but it's anyway good news that this process has started. Maybe just very briefly, since we are in the DTX conference right now, and discussing also the EHDS, I also want to highlight that Sitra has been funding some of the DTX pilot projects. So we had some pilot experiments that, for example, some of the university hospitals carried out together with the patients, and the patients were recruited. They were around 20 up to 100 patients that tried these digital therapeutic applications. We had one, for example, for asthma care, obesity and weight loss management, reducing the risk of stroke and coping with MS disease, and one also for improving the cancer care pathway. But I think the conclusion from all these experiments were that the patients were very much welcoming these new tools, because they got to take more active role in their own treatment and care. But also the healthcare personnel were very positive about this, but they also needed more support from these app developers to help dealing with the patients and the questions that they had, because they were also sort of middlemen here. So it's like improving these digital health skills not only among patients and citizens, but also of the healthcare professionals. And then one of the key issues was also this integration of the data to the healthcare systems. Now, of course, this in the future, this will be possible. It's also foreseen in the EHDS. But for example, one of the shortcomings in these pilot experiments in Finland was that this system was not ready yet for integrating this data for the patient portal in a very seamless and effortless manner. So I think in the future we will see improvements in that regard, and also EHDS can be seen as a sort of giving more motivation to do this as well in the future and in a better way, because of course, as we have seen and we have discussed and heard today, this comprehensive data is of course needed for validation and testing and improving also this kind of DTX solutions.
So thank you, Lina, even if it took a little bit longer.
Sorry.
But it's very good to know, because we will follow these pilots, because these provide arguments or explanations to the public, also to the population, on how that could help, but also identify some gaps to be addressed and some needs still. So we will be following that, following the update of the legislation, but also want to follow on the eHealth strategy in Estonia. So a lot of homework for the next months. But anyway, so we jump to the next speaker for this panel today. I want to invite Sander Pajasalu to explain what happens in Tartu University Hospital, one of the largest or the largest healthcare provider in Estonia with regards to health data. And there's, I think you have some slides, so we can just share these.
Oh, we can
Yeah,
pass
thank
it.
you.
Yeah.
Thank you very much. So first of all, thank you for inviting me here. It's a great honor, and I'm really excited to share my experience. So I was asked to prepare a few slides. So I'm medical geneticist, so a physician more trained in genetics, and I will give you this perspective, and I will also tell you a bit about my center, which I'm heading at the moment. And regarding genetics testing, it can be truly said that we are the largest in Estonia in healthcare setting. But because we provide services to other hospitals as well, and that's why it's, and we have very, very good collaboration with other hospitals as well. And it's, yeah. Okay, so I had a title in my mind, and I call it here as Precision Medicine Needs and Offers Data. So it's a two-way interactions what we really need. We can provide data, but we need data as well. And this is an important aspect. So a timeline about genetics or genetic medicine in Estonia is actually very much longer than we often think of. So the first genetic consultation clinic or service was established already in the 60s. And the Estonian Genome Project started more than 25 years ago. I was in elementary school back then. So the whole life of myself, when I have known what a gene is, I have known that there is a genome project in Estonia. And this is like, it's not so new anymore. So we still think about genomics as something very new and innovative, and it is. But for example, Estonian Health Insurance Fund started reimbursing exome sequencing, which is one of the largest sequencing assays used for patients and for diagnostics until today, more than 10 years ago. So we have collected large-scale genetics data in healthcare setting where the primary use is to treat or diagnose patients for more than 10 years. And the data amount is growing. And this is just an overview. I'm not going into details about the numbers of genetic testing. And these are only what are called next-generation sequencing assays, so the wide-scale sequencing assays. And you see that we have not plateaued yet. So it's still constantly growing. We have tens of thousands of patients who have been sequenced in Estonia in a healthcare setting. In some aspects, our data collection is larger than for example, Estonian Biobank has. Not as a number of samples, but the depth of the data in some cases. And this is a resource, and it's growing. It's around 100 terabytes at the moment, but we are currently procuring 2 petabytes of data and constantly giving calls and emails to our IT department that we are out of space. So, and this is a true thing, and we need to prepare for it. And but it's still a novel thing in a healthcare setting that we have to think about big data in a hospital environment. So I have been asked a lot that what do we need in order to make genetic medicine happen for everyone? We are doing very good in diagnostic setting. In Estonia, the access to genetic diagnostics is, I would say, the best in the world, or at least close to the very best of the world. So everyone who needs it due to medical indication gets it. But now, what about all citizens? Everyone, like Minister told us about her health risk based on genetics, everyone wants to know them, and they want to know them, well, they don't care but where the data assessment comes from, but they want good quality, medically usable data that their doctors can use. And of course you need data, but the data needs to be of high quality. It has to be findable, interoperable, reusable. But the very important topic, and will be discussed today later, I think, is the software as medical devices. But it doesn't stop there. You need doctors and healthcare professionals who can use this information. So you need training, you need clinical guidelines, and many different things. To deal with the implementation gap, in Estonia there is now a large-scale co-funded from European Commission and the Estonian government, the Teaming of Excellence project led by University of Tartu. And the Tartu University Hospital is also here. And we try to involve also primary care physicians to the clinical trials. We are currently, we are very soon to launch them. And we try to use this information and bridge the gaps to industry as well. But of course, large-scale projects take time to speed up. A few key messages from my personal view on this topic is that the genome is personal. Who owns the genome is far more complicated topic than some other kinds of health data, because you have inherited your genome 50-50 from your parents. So how do we deal with that, actually? So there are arguments that genomes are actually like national resource, what I think is true as well. Of course, international resource is as well, especially when we talk about rare diseases. The rare diseases are rare everywhere, so we need to collect samples to gain knowledge. But of course, although I'm telling you about genetics and genomics, genome is not everything. We need other health data as well. And we really need to be realistic, because otherwise we lose public trust in implementing these services. So this is really a key. To be successful, we need to be realistic as well. And yeah, so we really need to change from reactive medicine to preventive medicine. But it's a great challenge, but every challenge is an opportunity. So thank you.
Well, thank you very much, Sander. Thank you, Sander, for these reflections. They're perfect to open the floor also for the next speaker. But let me just continue for a second about the genomic data. Not only for the reasons you said, but also because if you have an identical twin, you don't want to share your data, but he or she goes to do it. I mean, what happens in those cases? Is there some legal subjects connected to that? And then again, from the legal perspective, I usually hear that the patients own the data, their data, but not every legal expert is agreeing on that, because from a legal perspective, there's not, let's say, something tangible you can own on that aspect. So, probably this is going to be challenged by our next speaker, Milis Just. I think that opens the floor, because in your case, the Chamber also provides insights for policy making. And yes, for sure you have an opinion on that regard that we want to share.
Well, I'm very thankful that we are invited here, so that the patient view is present. And in our case, we are an umbrella of 55 members, which everybody of them are working actually basically out of their needs and knowledge and focus, while we, if any of our members get in so to speak trouble, we are joining forces. So when we are advocating together. And also that we are a small organization, have been already across over 30 years. And I have to say that we are also members of two European-wide umbrellas. One is the European Disability Forum, and the other is the European Patient Forum. And it's the Patient Forum where actually the health-related and European health data space information also reaches us. So that is really important. And of course, as you said, we are advocating, we are meeting, and actually about a year ago, we met the Minister and the Minister of Social Protection as well in Haapsalu during our summer school, which is actually on today in Northeast Estonia in Narva-Jõesuu. So that is also one of the platforms. And increasingly, what we are doing is the information days on medicine, healthcare, and participating in different working groups. The Health Insurance Board Council, we have one member there, and several other working groups. So I'm just picking some of the topics. One is that the digital data, health data, what is available for our members and the individuals in each of the group is important that this is open and this is interoperable and solid in this respect. It's comparable and it's always there because as patient, our possibility to actually tell the doctors and medical personnel that please do and insert all our information is somewhat limited. We are working with it. It's getting better, but in the situation when you have to apply for status of disability or reduced working capacity, it's only the documentation which are valued. It's no physical inspection of the individual. So for us, that's absolutely very, very important. What I would also say that it was mentioned that digital skills are needed. We are struggling. Certain aspects you don't need to interfere, but if you want to look at your prescription, you have to be able to enter the health records and understand it. But we are also focusing, among other important tasks, we are focusing on improving digital skills of our membership, and we currently run an Erasmus project to be able to train the trainers, the peer support, as often there are a lot of assistance needed if you want to make a sort of, how is it called this, like if you are not happy with your findings, you can apply for a review. So all those for out of our perspective is really important. And also, of course, we are fighting for our rights, our smaller groups, for instance, rare diseases, for orphan drugs, so that in some countries, even in the vicinity, people are reimbursed. They are not in Estonia. It has happened also that some people have moved to Finland because of the medicine is available there. But time is running so rapidly. But I wanted to also just a few expectations. What we have is, of course, one is that there is a clear text or a clear and easy to understand information available in this very complex environment of health data, medical treatment, all that. So repeating, and don't be afraid of inviting our membership to participate, because being at the table, it's enabling us to be more knowledgeable. So that is one, and of course accessibility of information, that is also crucial. Often accessibility of information isn't focused so much on because it seems like extra burden, but I think Estonia, in the national level, the situation is improving. And lately, I just want to explain of one of the cooperation we have on rare diseases and assisting individuals or families who has a disabled child. We have a Swedish-Estonian cooperation with the University of Tartu and University Hospitals as well. Since 2003, they're establishing a private foundation. It's called Estonian Agrenska Foundation. And that is there we get some feedback and some aspects on how families with, for instance, a rare disease kid are coping. And it was interesting, as you, Minister, said that in Germany, there are the idea that what is happening in a doctor's office stays there. We have so many stories. The parents or a mother or a father were in the doctor's office receiving this rare diagnosis, and they got home. They don't know how they got home. That is not sufficient that he or she heard something in this first visit, because it's never remembered. The shock is that terrible. So this documentation for this respect is really, really important. And here in this center, not far from Tartu, we are offering respite care, interval care for children, easing the burden of care for families in order to maintain the family together and also maintain the mental health, and also with adults. And last year, when the Swedish royal family was on visit here, on a state visit, Queen of Sweden, Silvia, was visiting the second time our center. This is a very strong, permanent Swedish-Estonian cooperation. So she was together with First Lady, Mrs. Sirje Karis. So we are appreciating this positive attention, and of course we want to be as a network organization and also as the practical offer of assistance really on board in discussions. So thank you.
Well, thank you also. Thank you very much, Melis. And we only have like less than 15 minutes because lunch is waiting. But instead of 2 questions, I will only ask 1 question each, and please be very brief in like 1 minute, 1 minute and a half. And so for the Minister, for the eHealth strategy, you were mentioning several ideas ahead that you have. What would you like to see done in the next few months, years, in your administration and in your country?
We have discussed a lot about the long-term goals or like the good or ideal solution, but I think Sander was the one who mentioned we should be able to give something back, whether it's patients who have given their genome samples or patients who have their need now. We have to show that using data and personalized medicine and digital therapeutics, it can improve your life for condition now. We can make small steps. We know that the easy wins. And at the same time, that the goal is somewhere in 10 years' time, and we are moving in the direction, but we have to show something to keep the trust, because everything we do, it requires costs as well. We use public money, and there's no right to use public money if the current taxpayers see that they receive nothing in return. And although we discuss it in the health context, I really like the idea that Sander mentioned, that we get the genome from our ancestors, because my genome is unique, this is mine, and I can decide whether I want to know the genetic risks I have. I want to know, but some people can decide that they don't want to know. But for example, your, I think, a colleague, Mait Metspalu, researches the ancestral origins of Estonians. So even though I don't want to know my genetic risks, the genome also carries national value. So in researching I don't know what's the ancient history or origin of Estonians, how similar are we to Swedes? Do we come from India? I have no right to say that my genomic information cannot be used to discover the early history or roots of Estonians. So I can decide on health service use and this, but there is so much value for research and science in general outside of health system. And there, the decision cannot be mine whether we use the information to learn something new from ancient history.
So thank you, Minister. We keep that message because this is the one to follow as well. And now, Elina, you've seen a lot of different examples and landscapes. How can we sync all those different member states' speeds at the time? And also including the question about the researchers. Why do researchers don't want to use the European Health Data Space, which is the other, the other landscape that can be used if you want to access health data? What can happen on that level?
That's a very difficult question, but also very good.
Raised by the
good
audience,
question.
and probably we can go back to that after. Yeah.
Well, I think if we think about also the stakeholders that have been involved in the process and who have been more in-depth involved in the process of drafting so far, I think the research side has maybe not been so visible there or present there, for example, in our stakeholder forums. So it might be this kind of lack of communication as well, that we haven't really reached all the audiences in this type in a perfect manner. But I think it's also the constant challenge of having dialogue with the different stakeholders and increasing the understanding, especially now since we don't even ourselves know how the outcome will become. So it's like having this dialogue at the same time when the wheels are still also ongoing. So it's like jumping in a train that is already moving, but it's a similar situation for everyone. So I think for example, what we are doing in EHDS 2 now is that as we are producing these guidelines and technical specifications that will be, for example, specific for data users, they will be also specific guidelines for data holders. There will be specific guidelines and technical specification for the forthcoming health data access bodies. So it's like having this dialogue together with them, being involved in this drafting process. We have many stakeholders present in EHDS 2, but also we have public consultations. So all the documents will become first draft documents. They will be put out on the tehdas.eu website for public consultation. Everyone can see what is intended to include in these documents, how they could be improved. Is it considering my perspective? Is it not considering what is missing from the documents? So I think this is key information. We get to hear directly from the stakeholders how these documents will become more feasible, will become more user-friendly. And only after that, so this is a compulsory part of the project, only after that they will become final documents of EHDS 2, and they will be also published. And then the Commission will, of course, use these results to come up with their implementing acts. So it's not a direct process that we will suggest implementing acts per se, but there's a specific process for that. But of course, then EHDS 2 results will also feed into those implementing acts. But I think this transparency is the key.
Thank you. Thank you. And then we go to Sander. Data lakes or federated infrastructures or several health data spaces. Everything more complicated for the researchers at the end of the day, but...
Yeah, absolutely, and I have been thinking about this during past years a lot. And first I was really supporting the idea of putting everything together to one data lake, or how would you call it. But then the problem is, and I have been talking about this with many experts in Estonia and in other countries as well, is that there is a risk that the data producer loses the seamless access to the data. So in a perfect world, it wouldn't happen, but in the real world, there is this risk. And what it can cause, two things. One thing is that you will have a second copy in your institution, which is not preferable. It's doubling the cost. And the second thing which may happen is that if you lose access to your own data, and who owns, patient owns, but you understand what I mean here, that if you lose, it may slow down your innovation or your motivation to do data-heavy sequencing, for example, or other data-heavy data-generating things you do in your setting. Because why should I generate the data if I cannot use it for something really, really clever in the long run?
Yeah.
So that's the risks I see at the moment. But of course, in a perfect world, like in Estonia, the imaging bank kind of works very well between hospitals, at least. If the genetic bank in a healthcare setting would work as well, and all the access and everything is granted, then why not the data lake approach?
Well, thank you for that. And what would raise less concern about that, Milis, to the patients?
Yeah. Well, it's, as I said, that we are dependent on what is written in the health data records. So I think that if it's some mechanism that you can have, like after this first shocking experience, it can be also other, experiences, not only chronic rare disease, but of course also accidents and all that. That there are more possibilities to put your name down or put your condition in a system that there are additional assistance possible later, because this situation, when the actual first visit, second visit, third visit is happening, we cannot really ask the medical personnel to do everything what is there available, and then we are losing people. So for this proactive assistance, later on it's very difficult because of the data protection legislation to find those who could need help. And we are, of course, doing it a lot with our member organizations, but their hands are also too short. So I think that for this recording and health data, some additional possibilities could be created, but I don't know how to do it. Maybe there is a possibility with the app, so you can have an app on it. I don't know if I answered your question.
You
but
totally did. I mean, the problem is what happens with my data, and it is a concern, of course. But probably Riina has something to add here.
Short comment. I think it's relevant in the data lake federated system context as well. We are so focused on health data that we forgot, for example, with people, disabled people that Meelis represents, that information about social services, says, whether it's the home nurse or something else. And in general, for research use, we could also use the educational database. We have a very good database on at the unemployment insurance fund. I don't know, 20 years worth of data about labor status and all the services and training he or she has received. So if we want to a better service integration and provision, we are using data not just from health produced in the health system, but much wider. But currently the European discussion and agreement is about health data. But when we implement it nationally, we have to consider other uses as well, and maybe a federated system gives more flexibility in terms of that.
That could be a good way of seeing it, of course, and also is safeguarding the consequences that we may face, not for sharing, so losing privacy, but also which consequences might come from other environments that we don't control on that regard. So that's the concern. Time is up. I really wanted to open the floor for one question. I'm sure there's one. If you're not really hungry or not that much, we can have it. Yeah, at least a couple of them, yeah.
So, hello, I'm Vincent Vercamer. I'm working at the French Ministry of Health. I have a question regarding the title we have today. So, the question is, we are talking about the unlocking of the power of health data, and with the focus of the digital therapeutics, so which are medical devices and or software as medical devices. And the question is that, so we have manufacturers at some point, which are almost each manufacturer is a private company. So the question is that what is the, let's say, the main challenge for them to get the massive amount of data that they need to build the next generation of medical devices using the health data, because we know they need, or in some cases they need a massive amount of data. So what is the main, let's say, the main lock that we need to unlock in order to tackle these issues in, let's say, one sentence or one word?
I would say, of course.
Of course, in a secure and ethical way. I mean.
Yeah, for sure. And for example, if you follow FPIA or other associations of industrial stakeholders, you see all the concerns and all the needs. But who wants to take that one? Very briefly, because we have a second one and a final statement. Yeah.
I can very briefly just answer that. I think, of course, the investments to get the infrastructure running, but then I think there are still also some legislative hurdles. I mean that there is this interaction, the interplay between the different legislations. So it's not entirely clear, at least not for startups and companies who maybe doesn't have resources, or lawyers who are heavily, knowing all the details about the issues. So I think having this clarity about the legislations and the interplay between different legislations, also regarding the medical devices regulation. So I think those are the
thank you.
solutions.
I want to add here that EDA was inspired in Scambal Declaration. Probably in the lunchtime you can talk to Janos about that, because there's a second edition of the Scambal Declaration with EDA involving the industry, and they have a lot to say about that. So I think this is a good space also to discuss these subjects. The second question.
Thank you very much for the good discussion. Terje Peetso is my name. I'm from the North Estonia Medical Center. I just would like to call your attention to the wonderful existing initiative of the European Patients Forum called Data Saves Lives. It will celebrate its 5th anniversary this autumn, and I think that the fact that it comes from the patient organizations and it promotes the understanding that the health data is a public good, that all what we know in medicine comes from the data. And if we will now talk about opt-out, opt-in, data ownership, privacy, all these things, with the view of fear, then I think that we will get into the negative point. Rather looking this from the positive point of view, and I'm proud I'm in the scientific advisory board of that initiative. So I know that there is a lot of science back proving that this understanding is useful for all of us. So if the all levels, we come here, we have a wonderful panel with the experts. They would know that this initiative exists, and they would bring it up and say that patients themselves said. I worked in the European Commission at the time when the GDPR was negotiated, and I remember Eurordis, you know this organization of rare disease patients. They always took the floor and said, I don't know what are you talking about, we don't care at all about this data sharing because it is important, this is our life that depends on the results. So, courage. Thank you.
Thank you, and that's very good. Thank you for that. We all will be or are patients, but only those that are patients at the moment are sometimes feeling this way. So I think this is very important to understand that we are all patients. So thank you for your attention, your participation. Thank you for an amazing panel. And please follow the Scambal Declaration and EDA results, because we will continue providing this support to the European health data space and what happens around. Thank you very much. It's been an honor for me. It ran fast.
And now lunch. Lunch will be served downstairs, so we'll meet back here at 1 o'clock sharp. Thank you.